Good afternoon, everyone, and thank you for joining us. I hope you had a good day so far at the Ontario MD Digital Health and Virtual Care Show. And thank you for coming to our booth, virtual booth. So this is a new experience for a lot of us. What we want to talk about today is iCARE Virtual, presented by Health Espresso. And we're going to present on a regional model of virtual care, which is the evolution of telemedicine. So in the matter of telemedicine, it's already a given that people have already adopted telemedicine. COVID-19 accelerated that adoption in Canada. And looking at some of these numbers to go very quickly, we'll find that prior to COVID, 66% of Canadians usually would use an emergency room after hours and on weekends, so they have no access to their own primary physician during these hours. 50% of Canadians have actually accessed virtual care since March 14th, which is a very amazing number given that penetration of telemedicine before COVID was approximately 3%. 40% of Canadians right now are using virtual care, would prefer to continue using it as a first point of contact in the future. The problem here on the bottom left, as you see, is that most physicians were not prepared for the rapid switch to telemedicine. A lot of folks scrambled quickly. Hospitals helped maybe by making some Zoom and other tools available. But the reality is a lot of folks were not prepared for it, and some are still struggling with it. Looking on the right statistics, we'll find, of course, with the age difference, the baby boomers, which is the 50 plus, rising quickly, have a higher rate of adoption. So 76% are comfortable using technology for to connect with a physician. 52% already had a telehealth appointment with their physician, and 67% are willing to pay out of pocket for technology that would allow them to access a physician from their own home. Now, for me personally, coming from a home care environment, I know for a fact that a lot of the aging in place folks, especially when the weather is not good, would rather reduce the physician trips, whether it's a cold or a snowy day, and if they can facilitate that from home, then that would be a better option for them. Looking at the Canadian 65 plus, 88% of them already have internet and use it daily, and 65% own a smartphone, which facilitates access to telemedicine. Now, one thing we want to make clear today is the fact that telemedicine is not virtual care. So while we all scrambled to connect a telemedicine device in one way or another, that does not mean we're providing virtual care. It is no replacement for the in-person brick and mortar clinic. So what we want to do is hopefully capture that momentum that is happening right now in Canada, and maybe transition as many people as possible to a virtual care environment. So because virtual care done right can pave the way to increased efficiency in the healthcare delivery beyond COVID-19. So all of us and physicians know that not every appointment required a visit to the clinic in person. And as long as these K codes or similar codes are available, there's definitely a preference on both ends to provide a virtual care, provided that the physician actually has access to the patient data real time. Now, iCARE Virtual is a virtual care clinic that provides comprehensive family medicine via e-visits using connected electronic health record, which is Health Espresso. And today we're gonna just showcase how iCARE Virtual as a virtual clinic is leveraging the back end to provide a very good virtual clinic visit to a patient. and capturing at the same time all that fee for service and everything else that comes with it. So supporting a virtual patient care beyond the telemedicine call is really the focus here. So a virtual care, what is virtual care? When we talk about virtual care, a telemedicine, as we know it, is simply a phone call or a video call. It doesn't transcend that. Maybe there's an after call e-prescription or an e-visit with somebody else, but the reality is it ends there. Most of the apps that have exploded in the marketplace, without mentioning names, simply provide that in-person telephone call. However, if that same patient dials in 5 minutes later, they'll probably get a second or a different physician who has no idea what the first physician said or responded or advised, because there's no patient record to kind of record what happened on that initial call and the subsequent calls. So in a perfect world, a virtual care would improve access and continuous care, but more important, would stay local. So normally on a telemedicine call, you don't know who you called, you don't know who's picking up and where they are. With a virtual care, the preference is to have a physician that is regional or within the region of the patient, and even better if that physician is the same primary physician or somebody within their own group that supports that group of patients. A virtual care at its best would collaborate with all physician models, would increase the efficiency of the clinic visit, so the in-person visit would only be done if it cannot be resolved on a virtual environment. Now, with virtual care, you can also triage the patient prior to continuing and with the care, so that you can actually now set the ground rules for the next set of caregivers and service providers that will deal with that same patient. A virtual care at its best would also empower a local family physician by increasing their fee for service billing. I would actually revert to Dr. Termizi, who is with me on this call, to chime in and talk about the fee for service portion.
Hi, everyone. Welcome to the virtual trade show. Sorry about that. I'm Lubna Tremizi. I'm a family physician in Pickering. I'm also the Chief Medical Officer for Health Espresso. What I actually wanted to focus on really was to describe, I guess, from the perspective of billing and our experience as physicians during the first stage of COVID and then the second stage of COVID. I think just thinking back to March and April of this current year, I will tell you, I wear two hats as a physician. One is the fee-for-service hat, which is my work at the urgent care clinic, and I am also the owner of the urgent care clinic. Secondly would be as a salaried physician under the full physician billing model. Now, for those of you that are not aware, physicians do have two different billing models. One is just per person or per visit. The other one being a variety of different salaried models. So when all of this started happening and we had really to think of alternative ways of seeing our patients or providing care, taking care of our complex, really ill patients that needed to be connected to us. One of the things that I think the virtual world did really well is provided, and I like to think of it almost as the 3 C's for family medicine. So at that time, we had 3 problems to solve. I think the first problem was, how are we going to connect to our patients? So a lot of the virtual or telemedicine solutions, I would say, privately did that really well. They allowed us to, by phone or by video, connect to our patients. The second C would be, how are we going to provide continuous care to our patients? Now, again, I wear 2 hats. So as the family practice side, I would probably say that It was a little bit of an easier transition because I knew at the end of every month I was going to have a set salary or a set billing that was going to be there for me. So I had a lot of job security. I think on the side of the urgent care or fee for service, I panicked. I panicked as a physician. I also panicked as, I would say, a clinic owner. Our revenue went down to about 20% of patient visits, I would say, within the month of April, and stayed about the same in May. June started to pick up a little bit. Now, so continuous care, how are we going to continue to care for those patients beyond just that connection? Now, the third C for us is always, how are we going to make those patients come back? And how are we going to create revenue? For fee-for-service physicians, as well as for the urgent care side, that was a critical step because I think for a lot of us, knowing that there's all these private solutions out there that were helping us to connect to our patients, but at the same time, there was also these solutions that were connecting to our patients that were then actually, really at the same time, billing for our patients became a real critical concern for a lot of the fee-for-service physicians as well as the urgent care physicians. So to tie that all up, I would probably say, if I had to summarize, I was searching for something as a clinic owner, also as a fee-for-service physician, something that would go beyond that. So I could do my own virtual visit, but then I would also be able to have that continuous care for my urgent care or unattached patients. And then, and that is the electronic health record. I like to think of it as a shared care record, just because there's so many different partners in the care team. And then also the virtual platform there on Health Espresso really helped to bring my patients that were all in the vulnerable or high needs population. It really helped me to create a great sort of online identity for them, because I think just flowing through the different acute care pathways like emergency room or other urgent care clinics, they were lost to the system. So I think that's what we were searching for. And I think just one of the last things I will probably say is with virtual care generally, what we're trying to solve here is to give the whole picture of the patient, not just a partial picture, which the telemedicine platforms provide. All right, so with that, I'm going to sign back over to Rick.
Thank you, Dr. Termizi, for that. So the message here is telemedicine is not virtual care. So virtual care is more of a comprehensive approach to providing patient care online that can support the patient a larger ecosystem, for the lack of a better word, of other specialists, physicians, connect them to their home care environment and everybody else that touches that patient. So at iCARE Virtual, backed by unique, a collaborative connected electronic health record, documents the patient pertinent health history, and that basically brings us to a one patient, one care plan, so that when the patient is handled by different folks, whether it's the primary physician or the specialist, maybe having a at-home care provided by a physiotherapy agency or a home care agency or the LIN, it is everybody's on the same page. Everybody sees what everybody is doing. And if there's any medication or any adjustment that's being done, everybody's in tune, dancing to the same tune. Now, what does that look like? Health Espresso has two parts. One part is a mobile part that resides at the patient's home. It is free of charge, so there's nothing for the patient to pay for. And it facilitates also video connectivity to the physicians and the broader care team. While a lot of physicians right now are paying monthly fees for video connectivity with some of their providers, the video on Health Espresso is free of charge, and it's free to the patient. The mobile side, or the part that resides at the home, allows for vitals tracking, real time, and especially with 5G coming in, it will be instantaneous. It also allows for adverse drug-to-drug interaction check. So if one primary physician is providing or prescribing a drug, and a specialist prescribing another drug, they can actually see each other's prescriptions and avoid any mishaps. Medication adherence and medication management is also part of the mobile side. On the web portal, which now the physician would use and the patient has access to for a fee, you can actually now see a one care plan. There's all the digital patient record and digital patient profile, and everything is going to be connected to HRM, OLIS, OSCAR, and an EMR. So with Health Espresso, we're basically facilitating a two-way communication between all care team members, real-time access to patient data. The two most important parts is digital patient profile that is created automatically when the patient is triaged on the initial call. And there's digital care plan, which again provides a one patient, one care plan. Other features will include the remote patient monitoring, adverse drug-to-drug interaction, medication reminder, the e-visits, as we said before, and allows for the primary physician patient care team communication live all the time, and connectivity to all the government data services. We are building our own chatbot, and the chatbot is going to be community-based, where we actually can customize the information provided from let's say, physician care networks or LIMS or OHTs to provide regional patients with answers and information that they require based on where they live. E-prescription is in the works and will be coming soon. Now, who do we want to approach? We're looking to deal with folks in the primary care area that really want to continue with the virtual care approach, but definitely want to have a collaborative EHR in the background that allows them to continue providing that care to the patient, especially the distant patient, and possibly also include unattached patients to create another revenue stream. Under primary care, there's the collaboration for all physician billing models with regional physician registry. OHTs are being formed, and they were paused during COVID, but I know a lot of them are being kickstarted again. And OHTs are going to be basically a community or a whole bunch of community organizations that are working together to deliver care to the same patient. And what we have missing today is the fact that there is no tool to connect all the different organizations that are going to be working in the same OHT to handle that one patient. So again, Health Espresso provides that platform where everybody can connect with everyone on one EHR and have everything documented by skill set so that we can avoid errors and mistakes and duplicate care advice. Community organizations, of course, I know in the West End here, we're talking to Metamorphosis. There's the Alliance that covers parts of Toronto and Durham region that have anywhere from 80 to 100 community organizations. So efficiency of allied health partner tasks can be definitely increased using a comprehensive EHR. There's no replication of service among the different organizations. And again, the one patient, one care plan kicks in the same area here. And then we have on the private side, insurance companies where we can manage benefits, reduce cost for them. And retirement homes, of course, where a lot of the folks that are staying in retirement homes currently require a lot more care than originally planned for them in a retirement home or is available. And that's where outside agencies are usually asked to go in and provide that supplemental care. Connecting these patients, these residents in the retirement home area to their physician, to their care team can be again facilitated via a mobile virtual visit using Health Espresso. And of course, there's the critical health event prevention, which provides a higher attention for the retirement home. At this juncture, I don't know if you can see on your screen, there's a Q&A area. If somebody has a question for myself or Dr. Termizi, please type in your question, and we will be able to answer you online. I'm going to send a poll at the same time for participants. And the poll would be, are you currently using an EHR for your practice? Okay, we have one question. Are you useful for home care? And I'm going to answer that live. So the answer is yes. The essence of Health Espresso is actually, it started from a home care environment. Because as a home care provider myself, with iCARE Home Health, we have several organizations that come in and out of the home that really do not connect with each other. Physiotherapists come in and leave. Personal support workers come in and leave. The LIN will provide a nurse and come in and leave. And nobody knows anybody, nobody talks to anybody, and none of them also talk to the physician. So that was the inspiration for Health Espresso, and inviting a home care provider or a physician or anybody is as simple as adding an email address by the primary account owner, which is the patient. We have another question that says, is the mobile site difficult to use for a senior or a PSW? So the mobile site is available currently on both iOS and Android. It is designed in a very simple setup on the front end. It has its own artificial intelligence, similar to Siri or Alexa, where someone can actually speak to it and ask it questions, and it will reply back via a written message as to what the answer is. I have a third question. It says, language translation may be important to use. That's a great question from Dr. Crawford. So one of the good things we're doing is we're collaborating with Durham College AI Hub, and we are taking our chatbot and our kind of verbal answers now into the next level. By very soon we'll be providing a multilingual reply. So if somebody asks something in English, for example, or the solution, Health Espresso, asks something in English like, hi, Rick, it's time for your medication. Did you take your medication? And I am going through a bit of Alzheimer's, and I respond in Portuguese or Italian. Health Espresso will switch to that language. It will recognize the language and switch to it. And that's in recognition of the fact that 50% of the GTA now does not have English as a mother tongue. These are all good questions. There's another question here. It says, how will iCARE Virtual help me increase my billing? I will let actually Dr. Termizi respond to that.
So we apologize for the chair switching. We're just trying to be kind of COVID safe right now. So generally, what I would probably say is, as you all know, the telemedicine and virtual care solutions tend to really, whichever physician takes the call will bill the visit. There's two types of codes. There's the K codes, they're the temporary codes, and then there's the Q codes, they're hopefully the permanent codes for the virtual visits. Now for us, like what we're trying to do is, and when we say regionalize or localize and create a virtual care team that can take care of the unattached patients that are also might be the urgent care or after hours patients, we want to create a local registry of physicians. So taking, for example, the Scarborough region or the Durham region, any region for that matter in Ontario, what you want to do is create a physician registry whereby the patient goes online to iCARE Virtual, clicks on to register for an urgent care after hours visit, and they have a choice in terms of the clinician to select. Now, if their physician is in this registry or group, it could be a family health team sort of, I would say, delegate or a faux delegate taking the triage email notification. So that visit request will then go to that specific practice or physician. And from there, you have sort of the first right of refusal in terms of saying, do I want to take this after hours or urgent care visit? So over time, I think a lot of us are feeling that we can probably manage our after hours visits a little bit more efficiently. So we probably want that extra revenue. And I think that's what we're getting to when we say you can create the extra billing or extra revenue. On a side note, for those physicians that are salaried physicians, it would also help us create an after hours flow for our patients so that we can redirect those patients all to our own sort of triage nurse practitioner or triage nurse. Okay, thank you.
Okay, any more questions? Okay, we want to thank you for joining us. I believe if you want to access our presentation again, it will be posted on our YouTube channel and our Facebook page. Just before I go, I just want to read. We have one comment here. It says, "Virtual care to date has proven to often be more time-consuming than patient clinic visits, especially in allied team settings. Our team is reaching diabetics new to Canada. Many times reminders are really important. Where, how to get a test, does your platform help?" So this is actually a very excellent, comprehensive question. No wonder coming from another physician. So definitely a virtual care without any background about the patient will take a long time. And that's where we mentioned earlier that when a patient is checked into our virtual care clinic or using Health Espresso as an EHR in the background, they usually will answer a lot of questions or several questions for that physician that they have kind of requested to be the initial set of questions before they will actually get on the call. And this will provide the physician with a background about the patient, their name, their situation, and will triage them, create a digital patient profile for them that can be stacked on the call with the different outcomes of that call. Now, for diabetics new to Canada, I will actually revert to Dr. Termizi again. So many times reminders are really important. How do we get a test doses? How do you test for a diabetics that are new to Canada?
Okay, so you want to switch again?
Yes, let's do that.
I'm really loving this musical chairs thing here. So just, I think starting from, I'd probably take a two-step approach. I think on the mobile side, what we would do is probably with some of the different, we'll use a community health center or a similar type of clinical environment where there is different allied health professionals. Now from the mobile side, oftentimes you can use the caregiver or even one of the diabetic educators to help with uploading the information from the patient side. And you know what, even if you have to do it manually with the telephone entry, that can be done as well. Reminders, as Rick already stated, they do come from the mobile side for the physician, for the patient. When you get into the platform, you see these nice graphs where you can actually start to see the trends for the fasting blood sugar as well as the A1C. Now, there is a great section on the platform that has an active sort of live memo section where you can be messaging each other. So let's say if the patient or one of the allied health partners notices like a trend going upwards in the blood sugar, they can report it right away. So the physician or the nurse practitioner or the endocrinologist can see that and instruct in terms of dosing for the insulin levels or the diabetic medication. So our goal actually is to integrate, like Rick stated earlier, with most of the EMRs. And one of the purposes being, or one of the, I would probably say one of the key purposes being so that we can access the provincial assets. So things like OLIS and HRM, so that any of the recent blood work, the physician as well as the patient can see it, as well as all of the allied health partners. How that would help is, and one of the things I want to point out, so there's a few different things out there right now when you say that you're going to enter information from the patient side. From the patient side, you know, there could be errors in entry, just like from the physician or provider side. So with our platform, we wanted it to be pertinent health information, but safe in the sense that it can be entered from either the patient or the designate, which I would say is a caregiver or PSW, or it could be the provider or the allied health team. So I think the reason that's useful is that we didn't want to make it so complicated that it appears like an EMR, but at the same time, you don't want it so simplistic that the health professionals can't plug in that information and use it for analytics or outcome measures. Okay. Hand it back over to Rick.
Any more questions? Okay, our contact information is on the screen. We would welcome the opportunity to have a one-on-one with anyone who's interested in having a deeper dive to understand Health Espresso, how it can actually complement the brick and mortar practice into a virtual care practice. And if you want to also inquire about how iCARE Virtual can support your own practice after hours and on weekends, while you still are able to kind of retain your patient and without losing on your billing. Thank you for joining us, and I hope you enjoy the rest of the day today. I understand there's a lot of good, valuable material out there. So hopefully we'll hear from you later on with any potential opportunities to have a one-on-one collaborations. Have a good day and enjoy the rest of the conference.
Bye.